So the group of people that I'm identifying as othered by healthcare systems or healthcare providers are people of color who immigrated to America and live with a low socioeconomic status. And some of the biases I can identify that I hold against this group is that they'll always be considered as foreigners and othered because they, for one example, they don't speak English, or they speak English with a heavy accent, or they don't speak English at all. So it's just hard to communicate with them in that stance. So like we won't ever be able to understand each other. Like it'll take more effort from me to choose specific words for them to understand what I'm saying in regards to their care plan and their treatments and interventions that we need to do, as well as explaining their diagnoses. And it would be, this sounds really bad, but it would be easier for me to do all the talking so that I don't spend extra time or energy trying to understand them or to help bridge their knowledge about what's going on with their health and their illness. And also the fact that they come from a low socioeconomic status. And I just like relate that to them not being well educated. I assume that they just won't understand their diagnosis or plan of care because they have low education attainment. So it would just be hard for them to understand overall what's going on with their health. And that because they don't understand, because they have a low education, like they're also poor, like with low income, because they can't get jobs that have that will give them equal opportunity to live a more comfortable lifestyle. And so like many of these people of color are immigrants in America. Many of them come to America because they seek refuge from political unrest going on in their home countries. So with all the war and conflict going on in their homeland, their main focus isn't on their health. They're more focused on just surviving with the little that they have. And so it's important for me to dig deeper and go past the surface of society and reflect on the assumptions that I have towards people of color who immigrated to America that live in a low socioeconomic status, because based on the critical social theory, they are humans too, and just like me and just like anyone else that's born in America, they have feelings, they have thoughts, concerns, and desires and needs, in which I need to change my perception of this group so that I don't make them feel othered from me or the rest of society. This is important because othering dehumanizes, marginalizes, and denies their rights. It also, othering reduces empathy, and in my thought process should not be, well, they get what they deserve, because they don't deserve to be mistreated by society. Just like how Whitney Thor explained in a TEDx talk that she didn't deserve to be punched multiple times in the head for being fat. Therefore, the critical social theory helps me work towards freedom from social, political, economic, and ideologic conditions that contribute to my limited view and assumptions about people of color who are immigrated to America living with a lower socioeconomic status, because the critical social theory examines relationships of power and the underlying structures in society that produce population inequalities. Some of the biases I think that other providers may hold against this group of people is that people of color who immigrate to America and live with a lower socioeconomic status will never be healthy. They are frequent flyers because they don't prioritize taking care of their health. In this way, it's kind of manipulative that healthcare providers don't try a different approach to help make sure that their patients have the resources to get the care that they need. And so they'll just end up coming back into the same patterns and doing the same habits that they're used to. Another bias is that they don't care about their health. And this is problematic because it's not that they don't care about their health, it's that they have different priorities, such as keeping the lights on in their house because they need to make sure they can pay the bills, or they're concerned about being able to eat something at their next meal, or making sure that they're safe. This all leads to why people of color receive lower quality of healthcare. And then a third bias is that this group of people have symptoms that are not deemed serious enough by healthcare providers, that they won't even test them or provide them with the proper testings. An example of this is when Black patients were being sent home and dying at home from COVID-19, or they have more heart attacks that weren't prescribed the same medication as a white person. So there's inequalities there. And then how is the healthcare system set up to perpetuate the power structure that it prevents emancipation for this group? This is through the critical social theory that states that preventing emancipation is based on history. So it's what has happened in our past, what was the historical context at the time that impacts the relationship of how certain groups of people are seen in society. And then there's also the framing effect, which is a cognitive bias where our choices are influenced by the way they are framed through different wordings, settings, and situations. For example, it impacts our decision-making when things are said differently. So in that one article, they use PLWO, which stands for patients living with obesity, when referring to those patients rather than instead of using the term obese patients. So the emphasis is that the person that they're talking about or discussing is still a person, they're a patient, they require care. And it's not, and it's the focus is less on the fact that they are obese. And then a third part is that the prematuring diagnostic closure. And this is a type of cognitive error in which the physician fails to consider reasonable alternatives after initial diagnosis is made, because they're kind of like working within like a limited point of view, and they're not considering other causes or other explanations as to why this patient is experiencing certain symptoms. It's kind of like just one and done, like, okay, this is what I think, and we're going to move forward with that, rather than trying to really understand the patient. And then further consider the cognitive process covered in Cross-Carry 2013 article. How do these biases affect othering behavior of this population? I think that the type 1 intuitive process that is innate and hardwired in from our evolutionary past, and it's acquiring biases from our environment based on contextual factors. So in other words, it's how our feelings and emotions influence our judgment of those we consider as othered. And so it's just like an automatic like instinct, like what are our initial views, rather than reflecting more on that type of on what we're seeing in front of us. Like we just assume basically and move forward with our initial instincts rather than using the type 2 processing where it's more reflective. And it just basically perpetuates the fact that we are stigmatizing and stereotyping and biasing people who are othered. So after considering these power inequalities, what is the outcome? Essentially, there are power differentials that affect the relationship between patients and providers that lead to poor patient outcomes because they don't have a voice in their own health. So patients are less engaged with shaping healthcare organization and delivery. And do people in this group get equal care to people who are not in this group? I would say no. Providers assume that they have more power over the patient, which don't allow patients to speak up about their concerns and preferences. So people with power inequalities don't feel like they belong in the healthcare system, like they don't have a stake in it, and that they're not they're a part of it because they're the ones who are consuming the services, but they don't make an impact on it in a sense that they can make changes. And so people in this group lack the power within, which is the capacity to imagine and have hope for a better world. They are seen as people who come from unique and cumbersome backgrounds that just don't fit in society. And it should be that society, providers, should adapt and be open to their circumstances to better understand their situation so that they get the proper care. And so what are the effects on an individual in this group? I feel like that individual feels excluded and would not want to seek further care because they don't feel welcomed from the healthcare system. There's a distrust because of the way that they experience oppression from them. And then to the group as a whole, they would also distrust the healthcare system and unintentionally perpetuate the stereotypes and biases against them. And then to the healthcare providers, I think it'd be the same thing, perpetuating those stereotypes and biases. There won't be any change in the way society views those othered unless someone in that other category makes changes in society. Along with partnering with providers who do fight and advocate for them and try to make changes in society. If I could change the healthcare system to better meet the needs of this population, what would I do to design into the system, and how would I train physicians, APNs, and nurses to change their implicitly biased cognitive processes and ensure that these patients in this typically other group receive quality healthcare? I would just be more sensitive. Well, I would be more sensitive by recognizing that the biases they have made and the biases that I've made, and provide training or workshops that help other healthcare providers understand that those biases are unethical and unjust. These workshops would include an understanding of culture sensitivity and awareness, by seeing patients as humans with feelings and emotions, and by having a conversation with them free of judgment. To approach each patient, and to also approach each patient as a guest in our lives, and seeing how providers can best serve them. The workshop would also include how bias is powerful, and we need to remove power from those biases by recognizing it as detrimental to healthcare and detrimental to patients. To end this, how will I know if these theories are making a difference for my patients? Application of these theories would show that the patient is advocating and prioritizing their health. They're not avoiding healthcare, like receiving healthcare, because there is trust now built between the patients and providers. They're not fearful of how they're going to be perceived and judged and treated anymore, because it would be more equal. How would care look and feel like for patients and all working in healthcare if othering no longer existed? To me, I think that there wouldn't be any differences between groups of people. People would receive equal opportunities to healthcare. The quality of healthcare would also be equal. One group wouldn't be facing lower rates of treatment in comparison to another that is the majority. And then how would I know that these theories are making a difference? I would feel that there would be less negativity amongst healthcare workers. Like when we're doing the nurse shift reports, only facts are given so that the oncoming nurse starts on a clean slate with the patient. So rather than their experience and attitudes regarding the patient being colored by those who already provided care for the patient. Overall patient-centered care is achieved because the providers do what is best for the patient based on the patient's preferences, really listening to them and not doing what the providers want. Thank you.